Now, without like further ado, I would say let's like start our second presentation. Dr. Ambesh is ready. So over to you, Dr. Ambesh.
The thing is, as I told you before, that cancer is the second most common cause of death worldwide. And over the past 25 years, we have got advancement in the diagnosis in terms of molecular genotyping and molecular diagnostics, and in terms of newer anti-neoplastic drugs. These developments have led to the significant improvements in the outcome and survival. However, the cancer itself and the anti-neoplastic drugs have taken the toll on the kidney function. The combination of cancer with impaired renal function limits the effectiveness of anti-neoplastic therapy and decreases the rate of complete remission. The renal dysfunction in cancer patients worsens the outcome with adverse effects and increases the mortality. Patients with AKI has increased mortality. So there is you can say the kidney is often a silent victim in cancer care, whether it's a direct tumor effect or is the effect of the anti-neoplastic drugs. So there is an interplay between cancer and the kidney disease. The cancer can cause kidney disease, and the cancer treatment can cause kidney disease. And further, even the kidney disease can cause cancer and complicate the cancer care. Next, please. So in cancer patient, there is a complex interplay between oncology, nephrology, and critical care. There is a need for multidisciplinary collaboration like onco-nephrology, onco-nephro-critical care for early risk assessment, early recognition of kidney dysfunction, and early management of renal dysfunction along with modulation of the chemotherapeutics. Next, please. So AKI is common and it's a serious complication in cancer patients. When the patient reports for the AKI, by that for the cancer, by that time 11 to 20% patients have already developed the AKI. In the critical illness or the patients who are having hematological cancer, there the incidences may be as high as 27% to 50%. In a recent article published in 2019, they have shown that the AKI incidence has gone up from 18 to 52 per 1,000 persons a year between 2007 and 2014. And CKD is also highly prevalent in the cancer patients, and the incidence is 12 to 53% at the time of diagnosis. The highest CKD prevalence is in the renal cancer, that's 50 to 72%. In bladder cancer, it's 40 to 54%, and in colon cancer, it's around 43%, with an average reduction of estimated GFR less than 60 ml per minute per 1.73 meters square. So cancer in combination with the CKD carries very high morbidity and mortality. Next, please. Kidney dysfunction in oncology is a multifactorial. It could be tumor-related obstructive uropathy because of the direct invasion of the kidney, ureter, and bladder, or retroperitoneal lymphadenopathy or retroperitoneal fibrosis. It can trigger the paraneoplastic syndrome in terms of glomerular diseases, and it can also cause tumor lysis syndrome and acute tubular necrosis. Next, please. And the other thing is the treatment related. There's a chemotherapy, immunotherapy, targeted therapy, and chimeric antigen receptor T cell therapy. And these all three can cause ATN. Next, please. Cause acute tubular necrosis and nephritis and intraglomerular hemodynamic changes. Next. Other is the critical care related. That's a sepsis associated AKI, hemodynamic instability, and use of certain nephrotoxic drugs, various antibiotics, antimycotics, antivirals, and NSAIDs. They can also add to the AKI or start AKI. The other important part is the contrast that we use in the radiographic imaging. That can also cause AKI. Next, please. So AKI risk factors are either patient dependent or cancer specific. The patient specific factors are age more than 65 years, underlying CKD, diabetes mellitus, various drugs the patient is having like NSAIDs or ACE inhibitors or ARBs. And there are certain comorbid conditions. They can also aggravate like the cirrhosis liver, heart failure, and nephrotic syndrome. The cancer-related risk factor for AKI is neutropenia resulting in sepsis, post-nephrectomy after renal cell carcinoma, hematological cancer, urinary tract obstruction, post-hematopoietic stem cell therapy, thrombotic microangiopathy, tumor lysis syndrome, and other extra. Thank you. Next. So regarding, I will just touch upon the chemotherapy, various drugs used as a cisplatin, methotrexate, and ifosfamide. These drugs, basically the cisplatin, this accumulates in the cells of the proximal tubules and causes necrosis and apoptosis by means of the reactive oxygen species or signaling of the TNF alpha and mitochondrial death. Next. The ifosfamide, when this is taken up by the cells of the proximal convoluted tubule, it goes in the vasolateral membrane, and there it is metabolized into chloroacetaldehyde and acrolein. The chloroacetaldehyde is a nephrotoxic, it causes acute kidney injury. And next, please. Acute kidney injury. And this another metabolite is acrolein, causes hemorrhagic cystitis. Next. There is another cause of AKI is a thrombotic microangiopathy. It's a drug-induced serious complication and renal dysfunction. It's a dose-dependent condition, and it has got 4-5 stages. Grade 1, there is only RBC destruction, and grade 2 laboratory findings are there with the decreased kidney function and petechial hemorrhage. Grade 4 is life-threatening, and grade 5 is a death. Next. So this is the slide showing the glomerular denudation and capillary. You can see the arteriolar thrombosis. In the there are two types of drug-induced TMA. The type 1 is by the chemotherapy, and here its onset is delayed, usually between 6 to 12 months of the starting of the therapy. It's a dose effect. Basically, it's a cumulative effect, dose related. More the dose or more the duration of the dose, it can cause AKI, TMA. And there is a permanent, it's irreversible disease basically, and it's a highly probability of the recurrence if the patient is cured. It is associated with the high mortality, CKD and ESRD. While there is another entity as the contrast-induced nephropathy, and it's the third most common cause of hospital-acquired AKI. The rise in serum creatinine levels may be more than 25% or more than 0.5 milligram per deciliter from the baseline within 48 hours of the administration of the contrast. The other causes of the acute kidney injury must be excluded, however. Next. The signs of acute tubular necrosis are present. There's a fluid load and nausea, vomiting, azotemia. The diagnostic test is the estimation of the FENA, and if the FENA is less than 1, it shows the chances of contrast-induced nephropathy. Next, please. There are 3 pathways. I will not go in detail. First is when you inject the contrast, this causes severe renal vasoconstriction and inhibition of the local vasodilatation due to decreased nitric oxide mediated vasodilatation and causing tubular ischemia and cell death. The damage by reactive oxygen species is another contributing factor, and other is the direct toxicity of the contrast media causing tubular cell damage and death. Next. Another entity is the tumor lysis syndrome, and this must be taken in consideration. It's because it's again associated with the high mortality. The tumor lysis syndrome could be spontaneous, or it could be stimulated by the use of cytotoxic drugs. So once there is a destruction of the tumor cells, it lies and it produces, it releases intracellular compartment material. These are the potassium, lactate, phosphate. So the patient has hyperkalemia, and this hyperkalemia may produce cardiac arrhythmias. And here, because of increased lactate levels, the patient may be acidotic, hyperphosphatemia is there. The other things are the release of purine nucleic acids, that's adenine and guanine. This is metabolized in hypoxanthine and xanthine, and later it is converted into uric acid. So there is accumulation of the uric acid and crystallization and deposition in the renal tubules, and then causes AKI. And these patients usually have hypocalcemia. So clinical features are nausea, vomiting, muscle cramps, myalgia, tetany, edema, cardiac dysarrhythmia. They are all because of related accumulation of these agents. And there may be severe electrolyte imbalance. And if there is a hypocalcemia, the patient may show caustic sign positive and Trousseau sign positive due to hypocalcemia. In ECG, if you do, there may be peaking of the T wave, flattening of the P wave, lengthening of the PR and QRS interval due to hyperkalemia. And there may be lengthening of the QT interval also due to hypocalcemia. So these are the ECG findings you can see. The diagnostic workup should be done And there is a hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, and so these are the laboratory parameters, and one of the clinical parameters must be there, like the patient is having neurological symptoms, seizure, confusion, coma, cardiac dysarrhythmias, or AKI requiring hemodialysis. So one of the factors from lab and one from the clinical manifestation must be present before diagnosing the tumor lysis syndrome. Next, please. The risk stratification can be done in patients identify patients with high turnover cancers like acute lymphatic lymphocytic leukemia, Burkitt's lymphoma, metastatic breast cancer, etc. The patients who are poorly hydrated, they also are vulnerable, and the dose must be adjusted of anti-cancer drugs, and you can use the prophylactically resveratrol or allopurinol in high-risk patient. Close monitoring of electrolytes is required at least for 6 to 12 hourly interval. Next, please. So these patients require good hydration, use of resveratrol in high-risk cases, allopurinol in such cases. Next, please. And metabolic management is like the patient who is having hyperkalemia, hypocalcemia, or hyperphosphatemia, they must be managed. If the patient require dialysis, then they can go for the RRT. So early detection of AKI and kidney stress biomarkers are very important. You can use the urinary tissue inhibitor or metaproteinases and insulin-like growth factors binding protein 7. And these have been validated for AKI in critically ill patients. And along with the urinary neutrophil gelatinase associated lipopelin, that's NGAL, and KIM1. They enhance the early diagnosis and severity grading of the AKIs, which can help you in management of the patient. Other are the urinary interleukins 18 that acts as a biomarker for inflammation, and SUPAR, that is again for the associated with inflammation and CKD progression. Another entity test, we can use the furosemide stress test. That it is safe, standardized, and effective bedside assessment tool to predict the progression of early stage 1 and 2 AKI to severe stage 3 AKI. In a euvolemic patient, you administer IV furosemide 1 to 1.5 milligram per kg body weight and measure the urine output over the next 2 hours. If the total urine output is less than 200 ml or less than 1 ml per kg per hour in 2 hours, that shows AKI. And it also shows the signaling of the progression from severe from grade 1 to grade 3 AKI. The lack of response suggests progression of the AKI. So chronic kidney disease, again, that's another entity. As a CKD is a long-term condition where kidneys are damaged and cannot effectively filter blood, leading to the waste buildup. It usually develops slowly over 3 months or more, often with no symptoms unless advanced stages are achieved. Again, the eGFR goes down less than 60 ml per kg. And CKD appears to be both potential cause of consequence of cancer, increased risk of cancer with CKD, and patients with cancer have increased risk of CKD again. Kidney dysfunction creates an inflammatory and microenvironment and oxidative stress to establish an ideal environment for cancer development. So management, again, as early nephrology involvement, risk mitigation, monitoring of the various parameters, again, another entity is a new guideline is the cystatin C levels, because cystatin C is an early marker. It's better than creatinine. So you can, and it's more reliable than creatinine. Kidney biopsy, in some cases, you can go for the kidney biopsy, as Dr. Deshpande has told. So that's the last entity. Further ICU management, Dr. Deshpande has already told you, it's close hemodynamic monitoring and stabilization, renal replacement therapy, and sepsis control. Next. So in summary, close collaboration between oncologists, nephrologists, and intensivists is essential for prevention and early detection of AKI, as well as the appropriate therapy. So individualize the risk assessment and treatment to balance the cancer therapy and renal safety. Thank you very much.